we're recording. We'll pause for now. So welcome everybody to this PPGA GBM meeting. We will be presenting on gender inclusive reproductive justice and health. And we are also recording this meeting just so everyone knows. Anything you say may be picked up by the computer. So yeah, my name is Maddie. I use they, them pronouns.
I'm Erin, I use she, her pronouns.
I'm Valeria, I use she, her pronouns.
So yeah, yay.
Okay, so before we talk about the issue, we want to establish exactly what is important. So gender inclusive care allows for anyone who needs sexual or reproductive health services to feel comfortable and supported. So any person that can get pregnant should have the ability to decide whether they want the child or not, and whether they can raise the child or not. So the real issue is that LGBTQ members are one of the demographic groups that are discriminated from receiving access to proper reproductive justice services. So these resources consist of contraception, abortion, assisted reproductive services, HIV care, pregnancy care, parenting resources, and more. So in terms of discrimination, the National LGBTQ Task Force found that 9% of LGBTQ people and 21% of transgender people said that the providers used harsh or abusive language when treating them. 7% of LGBTQ respondents said that a provider refused to recognize their family status, and then 8.23% of transgender respondents reported that a provider intentionally misgendered them or used the wrong name. So back in 2017, the Department of Health and Human Services, HHS, issued a rule that healthcare workers could refuse to do anything that violates their personal beliefs. So this is in terms of like providing abortion services, providing gender affirming care resources, among others. And then LGBTQ members are the ones that are going to be affected the most if the healthcare provider is very religious or homophobic. So in terms of access to forms of contraception, besides Plan B, we have the actual Plan B, which is the pill that you take, and it's called the morning after pill. And then we have Ella, and then that's another form of Plan B, but just for individuals that weigh more than the actual Plan B requirement, which is more than 155 pounds, which is not ideal. And then this form of contraception is not too accessible just because you need a prescription. And if you don't have it, then you don't have access to this resource. Then we have CAP, and it's the one in the picture, also known as the diaphragm. And then you just insert them into the vagina. Then we have the IUD, which is the intrauterine device. And then it's also inserted into the uterus, and it's that one on the right. Then we have condoms, which Maddie will do a little demonstration later, as well as with the internal condoms, which get ready for that. Then we have the rhythm method, which just tracks your menstrual history to predict when you'll ovulate, and then you're able to just know when you can have sexual relations and hopefully get pregnant or not, or just avoid it, right? Then we have vasectomies, which is a medical sterilization procedure that cuts off the supply of the sperm to the semen. And then we have the tubal ligation, which is a medical procedure that ties the tubes. So yeah, these are some of the forms of contraception, not all of them, but these are the ones that we should be familiar with. So another issue is that there's a lot of misconception with the education that is provided for LGBTQ members or that is not provided. So healthcare providers assume that LGBTQ people do not need certain services just because they don't really pay attention to their sexual activities, what they relate to, and then what they identify with. So yeah, these individuals also like try to educate the patients, but with the wrong contraceptive methods. So like it won't necessarily apply to them. And then, yeah, they're just mal-educated in the end. The patients are, sorry. And then whenever it comes to the providers, they provide the hormonal birth control, but this has bad effects on transmasculine and non-binary patients just because the hormonal birth control contains estrogen or progesterone. I don't really know how to pronounce that. And then those can affect gender affirming testosterone levels, which is obviously not good. And then when it comes to sexual education, LGBTQ members are very, very excluded. So individuals do not see themselves in these practices. And then there's states like Alabama that tell the sexual education providers that like homosexuality is a sin, that you shouldn't partake in this and that. So it's not informative, it's not inclusive. And then if it was inclusive, we could prevent pregnancies, and then STIs, sexually transmitted infections, could be prevented. Now I will pass it on to the gender transition portion of this presentation.
Awesome. So before we continue, does anyone have any questions for Valeria or any of us? Okay, perfect. And for those who are coming in still, feel free to grab one of the pink sheets. It's two-sided. On one side are some resources that we'll go over at the end, and on the reverse, there's some like information about language and terms. Okay, so now we're going to talk about kind of what the gender transition process can look like for individuals, and you know, really that piece of it. Planned Parenthood offers pretty much every single service that I am talking about here. So if anyone is interested or knows anyone that might be interested in receiving these services, definitely you can talk to me. I can tell you about what the Planned Parenthood here in Charlotte is like. So before I kind of get into all of this, I just want to make one important note about like language. So there are a lot of things in here that you have maybe seen before, that are kind of structured as like female to male or male to female. And in this presentation, I'm taking like a degendered approach. So nothing is really going to have gender associated with it because gender is a social construct. We're really just going to kind of be using words like penis and vagina, ovaries, testes, and we'll go from there. If anyone has any confusions as we're going through things, please just let me know. So to get started, I'm going to talk about non-surgical versus surgical portions of the gender transition process. So some really common non-surgical things that people do during the gender transition process are coming out. So telling family and friends that they're transgender, non-binary, gender non-conforming, or anything. Maybe they don't adopt a label at all. I personally don't adopt any sort of label myself because they're all made up, and I don't feel affirmed by labels. The second thing that people do is change their pronouns. So people, you know, in the English language and some other languages, use a lot of pronouns, and the language is very gendered. So people need to sometimes adjust their pronouns in order to match with their identity. Another thing that people do is sometimes change their name. There are lots of different traditions within the trans community about like name changes that different people follow. Important thing to remember here as an ally is to just call people what you know they want to be called. And if someone has changed their name and you hear someone call them their old name or their dead name, to just correct them and move on. You want to take all the burden off of the trans individual or non-binary individual. Same thing goes with pronouns. I will again use myself as an example here. If someone says he about me, I don't say anything because it makes me really uncomfortable to get into that conversation. But I do really like when someone else says something for me, and I just don't have to be involved really. The fourth thing that people sometimes do in terms of non-surgical interventions is dressing or grooming in ways that they feel matches their gender identity. So I just kind of, oops, it's not letting me scroll on my notes here. There we go. Okay, so I am putting a little asterisk next to match your gender identity because that kind of goes against what I said on the first slide about degendering. The reason that I'm using that language here is because a lot of the times trans individuals do feel really affirmed by, identifying one certain way and kind of matching a lot of the stereotypes that exist in our society surrounding gender. So while gender is like a social construct, it is still real and is very prevalent in our society, even though I wish it wasn't. So that's why I say that. In terms of surgical interventions, we're going to kind of get into each of these on different slides, but there are hormones, top surgery, bottom surgery, and there are other interventions as well. Does anyone have any questions about the non-surgical stuff before we continue? Okay, perfect. So now I just want to quickly cover the fact that every transition looks different. So as we just kind of talked about, some people will never transition medically. They'll only transition socially, or the non-medical things that we saw on the left side of the screen. And there are lots of different reasons that this variation could exist. So the first thing is that people's desire to have medically transition just may not be there. In our society, again, there's been a huge, bold line drawn between anatomy and gender. We've really come to heavily associate people with penises being men and people with ovaries, vaginas, breasts, enlarged breasts, I should say, being women. There's no reason that someone who is a woman can't have a penis and someone who's a man can't have a vagina and can't have a baby and everything. So important to just talk about that. The second thing is it may not be safe for somebody to medically transition depending on where they're geographically located. Resources don't exist everywhere. It kind of goes along with accessibility to quality care. If individuals don't feel like they are receiving affirming care from a health provider, kind of like Valeria was talking about, it may be a real reason for someone to not transition. And also, the gender transition process can be really expensive. Specifically, a lot of the medical stuff that we were talking about is considered plastic surgery, which is considered elective surgery, which is often not covered by insurance, so it can be very expensive. Yes, that is a big problem, but that is currently how it is. And I put the word real there and cross it out because we never use the word real when we're talking about people's gender identity. You would never want to say someone's not a real woman or a real man or anything. That's really, no trans person is more real than anyone else, and it's just important to say that. So now I'm going to talk about hormones. I'm going to talk about the stuff that I find really interesting, and if I'm nerding out too much, then someone can just hit me and be like, let's move on. This is like the pre-med coming out. So basically, there's a lot of different kinds of hormones, but the two that people often use when they are trying to go through the gender transition process are testosterone and estrogen. Both of those hormones have a little bit of progesterone in there. So everyone kind of has all three hormones in their body. One like really common misconception is that people assigned male at birth only have testosterone, and people assigned female at birth only have estrogen. Everyone has all of them. It's just a matter of how much of each, and that widely varies between individuals. So hormones are used to do lots of different things. Now, like on a lot of websites, you'll see like male hormones and female hormones, and here you'll see that I've just said like deeper or higher voice, and then like more or less body hair growth, more or less facial hair growth, and then muscle growth, or redistribution of body fat, and then the menstrual cycle suppression. That's something that hormones do as well. This is just like a really brief overview of hormones. Anyone have any questions about them, what they do, anything at all? Okay, perfect. So top surgery is not that complicated. it's really, there are two ways that you go about it. Either people have breast tissue removed, so their chest becomes more flat, or they have breast augmentation, which is adding tissue from other areas of the body or artificial implants to make the breast area appear larger. And then bottom surgery. So there are a lot of different surgeries and methods to go about this. So these surgeries named up here are absolutely not all of the options that people pursue when they're going through the gender transition process. But so a hysterectomy is whenever internal organs like ovaries and the uterus are removed. And then a phalloplasty, usually people who are having a hysterectomy will have a phalloscopy at the same time. That's when a penis is constructed using skin from other parts of the body, often using grafts from the leg area. And also the part of the vagina is kind of like inverted outwards, and then over time, in conjunction with estrogen hormone therapy, it grows kind of outwards after you've also had a phalloscopy. So the medoidoplasty is a surgery that kind of, again, goes together with all of these. And it's a surgery that causes the clitoris to work more like a penis, along with hormone treatment to make your clitoris grow larger. And that's kind of what I was just talking about. It really is, that's why it's like a sub-bullet. They really go together. Someone doesn't have to have any surgery. They can have one. A lot of them do kind of tend to happen at the same time though. The orchiectomy is the removal of testicles. And then penile and virgin vaginoplasty is when the penis is kind of turned inverted and is turned into a vagina. So in terms of the orchiectomy, one thing I just want to say about that is that if someone just is on hormone treatment, is like taking testosterone or is taking estrogen injections, the testicles tend to shrivel up and over about 5 years just kind of shrivel away. So the orchiectomy is being done not as commonly anymore because it is like a painful procedure that takes a long time and is expensive and can be really traumatic for individuals. It is still done, but a lot of the times people just kind of wait those 5 years for the testicles to just kind of shrivel up and go away. So yeah, other medical interventions that people may have to help affirm their gender. Laser hair removal. I can tell you, I personally will be pursuing laser hair removal at some point. I hate the fact that I have hair that grows on my face. It disgusts me and I want it gone. So that's one gender affirming treatment that I hope to pursue at some point when I have the time. A tracheal shave is when the neck is kind of opened up and the trachea is shaved to make the Adam's apple smaller. It's not that common. It's not really a big issue for a lot of people, but it is definitely done. And then facial feminization surgery is something that occurs often as well. And again, I want to problematize the name of it. But the reason I'm using it here is because that is the name of the surgical procedure that doctors use, like that they bill by. But it's basically just when the shape is, the face is kind of reshaped to match the shape that people with ovaries generally are born with. Any questions about anything I've said before I move on to like the next section? Okay. So this section is going to talk a little bit about transgender fertility care. So it's kind of like the opposite of abortion, but Planned Parenthood helps out with this a lot as well. So transgender people who are trying to get pregnant often will have a lot more struggles than cisgender heterosexual couples, just because there are often a lot more challenges with the science involved. So I'm kind of going to talk a little bit about what would happen if you went to visit a provider who could help you basically get pregnant if you are trans, and we'll go through kind of the process and the options that they might present to you. So the intake process is pretty similar for visiting like any doctor. The doctor just kind of gets your history, assesses you, and then gives you your options. So the two main options that are usually used to help people get pregnant are an IUI, or an intrauterine insemination, and an IVF, an in vitro fertilization. There's something called a reciprocal intro vitro fertilization that we'll talk about as well. And then I just wanted to cover also trans women, so people who are assigned male at birth and have been taking hormones and stuff. So like if I were to start taking estrogen, that would permanently destroy my ability to be fertile. I'm already infertile because I had cancer, but that's like irrelevant. But basically, once someone starts taking estrogen, hormones, that kind of like, as I said a couple of minutes ago, their testicles start shriveling over time. And the viability of the sperm that's produced by those testicles is completely unviable in about 3 to 6 months. So trans women are generally advised by their providers to provide a sperm sample and store that in like a authorized storage facility before they start taking hormones, so that if they decide later in life that they want to use that sample with a partner or with in any way, they have that choice available. So the intrauterine insemination, I'm gonna try to like not talk too much about this because I just don't want to waste y'all's time, but there's a lot of information in the speaker notes of the slides about this that will be sent out after this meeting. So you can definitely feel free to read into that. But briefly, how the intrauterine insemination works. So basically, once someone is determined that they would like to get pregnant, so they meet with the provider, and then they have to make a decision. Either they have a person with testicles that they're not receiving like estrogen treatment that they could just provide a sample right there. They have a frozen sample that they could use, or they have a donor in mind, or a random donor. So those are kind of the 4 pools that usually fall into. So how this works kind of behind the scenes is that once the sperm sample is collected, it's washed. A big problem or reason that people usually have trouble getting pregnant is that like the sperm are not clean, and so they're washed chemically using a process that takes everything out besides for like the actual sperm cells. This is also useful information for people who are cisgender heterosexual identifying women. Sometimes like pregnancy, like there are fertility issues, and IUI is a really good method to use. And that could be because like someone may be allergic to some of the things that are contained in semen besides for the actual sperm cells. And so the kind of collection and washing process is sometimes used in that situation. Because whenever you're having an allergic reaction in your vagina, you're not going to get pregnant. It's not going to feel good or go well. All of that is usually prepared or paired with like fertility medications that help people to move the process along. Is a lot in the speaker notes about that. And in terms of what to expect, this is usually a really quick procedure, about 5 to 10 minutes. It's more the planning process that takes a while and can be really time consuming. The side effects are pretty minimal besides those which are traditionally associated with pregnancy. There's not really any side effects with this specific procedure, besides for the fact that, you know, going through this process is an intense and emotional process. It's also definitely less expensive than the other process we'll be talking about. Is usually completely covered by insurance. In terms of the in vitro fertilization, so this process is, I would argue, more interesting. It's usually used for people who are having a much more difficult time getting pregnant. So basically, someone may have to go through like a bunch of cycles of IVF before they actually are able to get pregnant. What happens is the eggs are harvested, and And then like in a lab setting, a doctor uses a sperm sample that's been collected and washed that we talked about before. And the person with the eggs has been taking fertility medications to help their eggs grow more healthily. And then the provider will kind of harvest an egg and make sure that it's in a good state to try and be fertilized. And then they will fertilize it outside of the body. And then ideally it works out, it gets fertilized, and then it's put back into the body by the doctor. The side effects for this one are a lot more substantial. There are definitely a lot of negative side effects with this procedure. It can be painful, both physically, emotionally, and there are also kind of a lot of things like headaches, nausea, vomiting associated with this, just because there are a lot of medications and chemicals involved, and it is very expensive. Without insurance, each cycle of IVF can cost around $10,000. Let's see. Just a couple of other forms of assisted reproductive technology. The previous one and IVF are like assisted reproductive technology. Cryopreservation, which is when sperm cells are preserved, like in a freezer or something, is inherently a form of ART. So yeah. And then we talked about this before. Trans women or non-binary people or anyone really that is taking estrogen who is born with testicles will not be able to provide viable sperm after a pretty short period of time. So yeah, that was a lot of talking. It's Aaron's turn to talk. But does anyone have any questions? Yes.
I don't know. I feel like every now and again you see in the news some sort of like science figure out how they, I don't know, they're trying to figure out how to produce like a fetus from 2 eggs instead of an egg and a sperm. I don't know if you know anything about that or like if they made progress on that or how, I don't know. Because I feel like I've never heard of it actually being like a viable thing yet, but I do hear about it popping up every now and again. It's like people are researching it and supposedly having some sort of like progress. I don't know.
Yeah, so I've heard a little bit about this. I like whatever I'm spewing right now is not necessarily the most up-to-date information, and like anyone else who knows, correct me if I'm wrong. But from what I've read about this, like it will be possible. Like it's the research is still being done on it. A really big reason I think that we haven't seen more progress is that completely bureaucracy and politically, people are very kind of hesitant at the idea of being able to produce a baby from 2 eggs. It's kind of just like genetic modification of embryos before they are viable. So altering an embryo like after conception is possible. There are just ethical concerns, and I'm not saying I completely disagree with the fact that there are ethical concerns with that. I think that it's possible and it could have been done, but I think that it will take some time for us to see that, mainly due to politics. Any other questions? Okay, fantastic.
Happy National Abortion Providers Day. Hope you all got a donut.
Yay!
And I hope you all stepped on the posters that were on the ground. I'd first like to give a trigger warning about the content. If gender dysphoria is triggering you at all, feel free to take a water break or just completely tune me out. I just want to make sure that you're all aware before I start. So another relevant topic in this broader discussion is the reality of limited access to, this is a big word, just means like abortion causing services, abortifacients. Sorry, don't want to sound pretentious, but so access to abortion is particularly significant for both the LGBTQ+ and the gender minority communities because they're twice as likely to experience or cause an unintended pregnancy. And especially for the trans masculine community members, carrying a pregnancy to term can elicit extreme feelings of gender dysphoria. So there's a greatly exacerbated need for easy, affordable, and safe ways to access abortion for all communities, but especially these ones. So while trans and gender nonconforming individuals are theoretically able to access abortifacient treatment, there are a multitude of barriers which actually prevent them from doing so. First and foremost, trans individuals on average make 70% of what their cisgender counterparts make, regardless of their level of education, which is astounding. For this and many other reasons, individuals within the trans and gender minority communities are disproportionately more likely to be impoverished, to lack access to transportation, to lack access to insurance coverage, and to lack access to secure housing while they're resting or recuperating. Additionally, the trans and gender minority communities are communities which already carry the burden of intense social stigma and discrimination, and seeking abortive measures, unfortunately, only adds another dimension to that stigma, which may prevent them from seeking formal care and instead may incentivize them to seek out more dangerous informal methods of abortion. A study published last year estimated that of the 36 of the trans and gender expansive participants that participated in the study who had become pregnant, about 20% of them had sought informal methods of abortion, basically taking it into their own hands, which, as we all know, is like extremely dangerous. On top of these intersecting forces of discrimination, trans and non-binary individuals are often erased from the discussion of reproductive healthcare in general. So therefore, research into the appropriate healthcare is severely lacking. Thus, they're often unaccounted for in clinical settings and experience even further marginalization when they do try to access it. And lastly, prominent pro-choice figures often use gendered language like women's bodies, women's healthcare, that kind of thing. It's supposed to be kind of a rallying call, but it actually ends up marginalizing a lot of people that really need access to this care. So like Maddie talked about before, we're trying to be very intentional about not using that kind of language. Another significant barrier to the accessibility of reproductive care is more general clinician bias, which has kind of already been a little bit discussed. So I'm going to kind of recircle back to that, but add to it, because the bias manifests itself in several ways. So clinicians tend to make several incorrect assumptions regarding proper treatment and screenings for LGBTQ+ and gender minority communities due to a lack of intensive education or personal implicit or explicit biases. Frequently, clinicians will insist on administering screenings or tests which align with an individual's assigned sex, even though they make absolutely no sense in the context and are completely against the consent of those that they are trying to administer it on. Microaggressions, although I really don't think I'd call these aggressions micro at all, are unsettlingly common amid clinical settings. In a study conducted by Lex Police Farrow, trans individuals frequently reported that their clinicians had assumed that they knew what was best for them, even though the clinicians were entirely wrong. Moreover, clinicians often assume better information regarding the trans and gender nonconforming communities just don't exist, which is otherwise known as institutional erasure. So they don't really seek out ways to fix their mindset or gain more educational opportunities. Clinicians also often unintentionally or intentionally erase the chosen identity of their patients by using incorrect pronouns, dead names, administering improper tests, like I said, without consent, or just generally being very intolerant of gender identities which lie outside of their own personal understanding. Worse still, because of this level of ignorance, trans and gender minority individuals are often expected to be the experts of their own care, which kind of entirely defeats the purpose of going to a doctor, because why would you do that if you can just figure it all out yourself? So as you might imagine, all of these experiences are really likely to trigger dysphoric feelings, and trans individuals therefore are more likely to experience even higher levels of distress after experiencing microaggressions. So perceiving such blatant homophobia and transphobia might entirely dissuade someone from disclosing their true identity or from their gender identity, or prevent them from seeking any form of formal care at all. And that restricts them entirely from accessing safe measures of abortion. So all these dimensions of discomfort, bias, and harm at the hands of clinicians ultimately results in much poorer health outcomes for the community. It's a really heavy topic, but hopefully there are ways that very quickly we can ameliorate this issue. While concerns regarding clinician bias and other barriers to access are definitely complex, there are ways to make it better, like members of the LGBTQ+ and gender minority communities have expressed a desire for clinicians to just ask more open-ended questions like, what are your pronouns? What is your name? Like, what is your history with gender affirming care? Things like that, like what recent operations or non-surgical procedures have you completed? That allows them to be able to adopt a plan that actually takes into account the needs and history of the individuals. Consent also obviously should always be asked for when completing any sort of examination, and especially in this setting. And lastly, formal medical programs and general sexual health programs, as we talked about a little bit before, need to devote more of their content to the specific needs and requests of those in these communities. So fortunately, barring complete institutional overhaul, unfortunately, the problem won't be like completely eliminated, but this can make it a little bit better at least.
Okay, so we're just kind of wrapping up here. I just want to talk about the resources that are in front of you. There are a couple that are on here that aren't on the sheet due to like mainly the space constraints, but the most important ones are on your sheet. So I personally like to split resources into 3 separate categories: getting information, getting treatment, like medical treatment, and crisis support. So in terms of getting information, there are listed here some Davidson specific resources as well as national resources. I'll just highlight the Planned Parenthood website is amazing, and pretty much everything on there is degendered already, which is amazing. Love it so much. In terms of getting treatment, on the top there are a couple of medical providers in the Davidson, Charlotte area. The third one down is the main citation, which is in the speaker notes for the transgender fertility care of the portion of the presentation. I think you were there, Alona, when Dr. Johnson came to do the presentation. She does a lot of work in the Charlotte area. She's great. And then there are some national resources listed here as well. In terms of crisis support, I was kind of rolling my eyes at even putting this health center on here, considering that they're often not very accessible to students. I did go with including them on here just because I had a feeling someone would yell at me if I didn't. But I will say in creating this presentation, I did call the bottom 2 numbers and selected like that I didn't have an emergency, that I just wanted to get information. And both of them sound like really good 24/7, 365 resources that are available to people. The Mecklenburg County Sexual Assault Crisis Hotline is, I believe, like their office is in like either Mooresville or Cornelius. And they do have like not a bus, but like a vehicle that they can go and like help people in the moment. And that's like a confidential option that's available to people. So that's really great. There are some national resources on the bottom as well. So that's all we have. Any questions before we do a little entertaining activity? Definitely. Yeah, maybe I'll maybe like make it a little prettier before we do that, but definitely. Okay, so I'm just gonna put the computer out here. Would you all like, we should do this together because this is like a group idea. So we're gonna demonstrate how to use an internal condom as well as an external condom, but people know how to use external condoms. What we're really trying to do here is demonstrate the use of the external or the internal condoms. I'm sorry, because a lot of people don't know how to use them. And so even if you're not going to use one, it's good to know so you can tell your friends and everything. This is for the second portion where we demonstrate the external condom. I couldn't find anything better than a water bottle to demonstrate the internal condom. So I'm going to kind of narrate this as we go along here. So this is an internal condom. They are available for free on top of Wellness Wendy. Yay, Wendy. And on the package, you'll see that it says female condom. It's not a female condom, it's an internal condom, but printing error. So we will pretend that this water bottle here, this is not really an accurate size of either a vagina or an anus, but pretend it is. So basically the first thing you'll do is just open up the container. we'll pretend that I had just washed my hands. And so you'll see two kind of rings here. So this ring in the bottom is only for use if you're using this inside your vagina. If you're using this in your backside, you'll take the ring out. I'll demonstrate the first way first, and then we'll go back and do the second way. It's so exciting. There's so many things to do. So basically, if you're putting this in the front side, in the vagina, you'll put it in, and then you would pretend that this hole was bigger and it would be easier. And then what you'll do is, again, the water bottle is very small, but what you do is you kind of go in and you flatten out this ring so it's all the way in the back, and then it's just like kind of creates like a, you can just visualize it. Oh, it's stuck. Getting my hands dirty today, Erin. You would pretend that you kind of have a nice large receptacle, for lack of a better term. And then could you just push the orange button? That's for me to take my antidepressants. You would pretend you would put in either foreign objects, whatever, really. And it would just go right in like that. Important note, don't use an internal condom and an external condom at the same time. Just pick one, because if you're using both at the same time, then the materials, which are made of the same thing, will make each other break, and that defeats the purpose of both. So yeah, just quickly, for the if you're putting this in the back side, you'll want to make sure you take the ring out, because you probably won't be able to get it back out, because the muscles in your anus are very strong, and they'll kind of pull it and just keep pulling it up, and then before you know it, this whole thing is up in there, and then you're in the emergency room and your weekend's ruined. So what you do instead is you put it in, and then this keeps it on the outsides, and then y'all will leave it up here, and you can feel free to come and see it. But this ring is a lot harder than kind of the outer one, which is, you see on normal condoms. So yeah, love that. Okay, so that's the internal condom. I'm gonna leave it right there. My hands now have lube all over them. But oh well, taking one for the team, I guess. Oh no, don't fall. Okay. There are also dental dams up here. So I guess we'll demonstrate that quickly. It's not. Would you like to demonstrate? What if you want to demonstrate the dental dam?
Well, to a certain extent.
No, just like putting it on, keeping our masks on, obviously.
How do I open this?
Well, my hands are slippery, but there's like a little preparation in the packaging. Yes,
sorry.
This is a tip I learned once from experience. Open the container before the lube, because otherwise you will have trouble opening things. Did you get it?
Oh no, does anybody have scissors?
I can open one of the ones that's up.
Thank you so much.
Yeah. This one I think is vanilla flavored.
Vanilla flavor.
Or the grape one?
Okay, so basically it's opened. So it's wrapped up very nicely here in like a thing. It's yellow.
No.
It's now been contaminated, so open a new one. But so basically, if you can find how to unfold it, you just unfold it. Oh no. There we go. Okay. Great. It's very flexible and stretchy. And if you think you've unfolded it all the way, double check, because you probably haven't. It gets bigger. These things stretch out like so much, and they're great. Okay, so then what you do is you just put it like that, and then go to town. So that's that. And then, okay, the last thing we'll demonstrate, and we'll leave things up here in case anyone wants to practice, is the traditional condom. This one is red. Very fun. So this is the most messed up one out of the three, I think. the first thing to do is to check the expiration date. Looks like this one expires on January 1st of 2023, so we're in the clear. Something that a lot of people do, this one time, silly man, I can't say this because it's being recorded, actually. I'll say it after I stop recording. Something important to make sure is that you make sure it's facing the right way before you put it on. Because what some people might do is put it on and then it's the wrong way and then they turn it over. Well, guess what? Now it's contaminated because you put it on the wrong way and it could have stuff on it, so things could happen. So to test it, you'll put it on your finger and then you just roll it down a little bit to see it's facing the right way. Looks like it is. So then what you do, would you mind holding up the device? Yes. So you'll kind of like hold a little pinch and then leave some space at the top, and then you'll just put it on there, and then you just roll it down all the way. And then you again go to town. And then when you're done, you'll just carefully take it off. Make sure to take it off away from the partner that it was being used with. It was being used with partner, because again, we don't want to defeat the purpose of the whole thing. And you'll promptly put it in the garbage. And if you're feeling extra cautious, you can tie it off to make sure that there's no contamination at all. And then put it in the garbage. Any questions? Thank you. Okay, that's it. You want to close that, and then I can just tell you